Thank you everyone for joining. We'll get started in just a couple of minutes.
Okay, I think we can start. Good morning, good afternoon, and good evening, everyone. And thank you for joining us. Welcome to the fifth installment of the COVID-19 webinar series. This is hosted by the Joint Perfusion COVID-19 Task Force. Today's webinar will focus on COVID-19 treatment and the preparation for ER reopenings and putting patients back on CPB. We are thrilled to have a host of panels of physicians from Antwerp, Belgium, Ankara, Turkey, and Aurora, Colorado, USA. So today's webinar consists of 3 presentations. Each presenter will present for 10 to 12 minutes, and there will be a long Q&A session afterwards. So we'll first have 3 presenters and then the Q&A session. So our first presenter will talk about the organizational aspects of getting patients back in the OR safely. This is Dr. Guy Hans from Antwerp University Hospital. He's a chief medical officer and anesthesiologist. Our second speaker will talk about the clinical aspects of getting patients back on CPB. And that will be Dr. Serdar Gunaydin from Ankara, Turkey, from the Department of Cardiovascular Surgery there. And last but not least, we have Dr. Michael Firstenberg, and he will give us an overview of the medical treatment options for COVID-19 patients. He's from Colorado, USA. My name is Luc Peus. I'm a perfusionist from the Brussels area. I'm currently living in the United States. And my co-hosts are Bill Harris and Al Stammers. Bill Harris is the director of ECLS services at perfusion.com. He comes from New Orleans, Louisiana. And Al Stammers is the vice president of the clinical quality and outcomes research at Specialty Care from Sweet Valley, Pennsylvania. Today's broadcast, as always, is recorded, and you can look at it on YouTube for future playback. After the presentations, as I said, we will have a question and answer session, and please feel free to use the Q&A function at the bottom of the Zoom presentation to submit any questions you may have during the presentations. We will do our best to answer as many questions as possible during the Q&A section. Everyone will be able to see all the questions submitted, and you can upvote questions if you feel that this is a question that you want to see answered, or if this is the question that you wanted to ask, you can upvote it, and most votes will, if it's appropriate, will be the questions that we will try to get an answer for. Okay. So if your question is not answered during this webinar, you can always submit it to the discussion forum. And we, members of the task force, will also monitor this discussion and try to get your questions answered, sorry, as quickly as possible. Next slide. Yeah. So this meeting has once again been approved by the American Board of Cardiovascular Perfusion, and they offer up to 1.5 category 1 CEU credits. And also the European Board of Cardiovascular Perfusion has approved this webinar to earn 1 scientific point for attested participation. All attendees of the live webinar will be emailed a link to complete a brief survey to claim credits within a day of the broadcast. And certificates will be provided within a few weeks. Even if you do not plan to claim credit, we would still like you to submit your questions to the survey, because there is also the task force is seeking information on the operating status of your program, and also on the program capacity. So the survey is meant to be executed, and then the results will be presented in the next webinar, which will take place within 14 days. Okay. And today's webinar is generously sponsored by Medtronic, who covered the administrative costs of the ABCP CEUs. Okay, so we will start the webinar, and I invite Dr. Guy Hans to the podium for the first presentation. Thank you.
Thank you for the introduction. Welcome everybody. Good evening from Antwerp, Belgium. I was asked to briefly talk about the organizational aspects of restarting an OR, but even restarting a hospital after the COVID-19 pandemic. So in Belgium, all hospitals were locked down, were placed in lockdown by the central decision of the Belgian government, and since about 2 weeks we were allowed to restart our activities. Next slide, please. I think for our hospital, 4 elements are crucial in whatever we do and what steps we are currently taking. First of all, making sure that our patients are safe getting into the hospital, during their stay in the hospital, and getting out of the hospital. But also the other patients, the fellow patients, need to remain safe. And third, also important, is that the healthcare professionals are also safe when they work with patients and in all circumstances. And certainly in the ER, that can be indeed a challenging thing to do. And therefore, we created a kind of sequential and layered protective system. We call it several lines of defense, where we triage the patients before they get into the hospital, so that we are safe about the COVID status of the patients that are in our hospital setting. Next slide, please. So in order to keep our patients safe and the fellow patients safe, we decided to screen every patient before hospital admission. During the height of the pandemic, we admitted patients, then we would perform the screening, we would keep them in a separate room, and we would wait for the results of the PCR, which can take up to 4 or 5 hours. Of course, when you restart the hospital and a lot more patients are coming in on a daily basis, that is impossible to keep with. So we now switch to a home-based screening process. So on day -4 before the scheduled admission, patients are contacted by telephone by our central admission department. There is a questionnaire that is completed. If already from that questionnaire some signs or red flags with a potential COVID infection are raised, then the admitting physician is contacted. If there is a code green, what we call, then we will schedule a visit by a nurse at home of the patient where the swab is taken, and that is either on day -2 in the afternoon or late evening, or day -1 early morning. All swabs are brought to the hospital. We do the screening, the PCR. So at the afternoon, the evening before the admission of the patients, we have the screening results of all patients, and the admitting physician still has the time to cancel or delay the admission if a screen reveals to be positive. Currently, we see that about 3.4% of our screenings are positive, and in most cases, these are patients without any symptoms leading to or pointing to COVID-19 infections. Next one. So the COVID status has to be available at all times, and that can be something challenging if you have a longer stay in the hospital. At the beginning, we said, well, if you have a negative screening, that will remain valid during 48 hours. I think we were too severe in that, and so we enlarged it to 5 days. So if a patient remains in the hospital more than 5 days and an invasive treatment is scheduled, then we will rescreen the patient again. Also important to maintain the safety of the patients and healthcare professionals is, of course, that we have sufficient personal protection equipment and also proper use of it. And that changes, these protocols change also over time. The big problem we had, and I think a lot of countries were faced with that, is that there were insufficient protection equipment available. So a couple of weeks ago, 6 weeks ago, we started with a disinfection method within the hospital, and we have several disinfection methods that we now use on the hospital campus so that we are self-sufficient in our protection material, both for mask as gowns. Continuous training and retraining of all personnel is really important, certainly in the OR, but also in the ER, but also on the wards, because in the beginning, the COVID-19 patients were concentrated in transit wards or COVID wards, but now you get to see that COVID-infected patients start to pop up in all of the wards, and they are hospitalized on their basic specialty. So we need to really train all nurses, all physicians, in order to be sufficient in the use of the PPEs. And this also requires an efficient communication within the hospital when a protocol changes, when the screening procedures, the triage procedures change. We need to communicate that so that everybody working within the hospital knows the correct procedure. Next slide, please. What we also did, and we do it not only for the patients who are admitted, but also for the patients, the ambulatory patients, daycare, or for consultations. 48 hours before their consultation or their appointment, we send out a digital questionnaire looking for symptoms of COVID-19 or looking for recent contact with a COVID-19 patient or for a proven COVID-19 infection in less than 28 days. They complete it digitally, and on the basis of their their answers, we stratify them in either a green code, there's no problem, no symptom, no contact with a patient, or an orange code when they have no contact, but when they have some symptoms like sore throat or loss of smell or something, or a red code when they are possibly infected with COVID-19 themselves, or they had a close physical contact with a person who is proven to be infected. The red ones have a separate flow. They have a separate waiting room outside of the hospital. We have a COTRA team, a COVID transport team, who picks the patient up and brings them to their room or to the consultation ward. The green and the orange one get a QR code on the basis of their digital questionnaire, and they can quickly transit and enter the hospital through a kind of fast lane. We created outside of the hospital a kind of triaging system with fast lanes, like in the airports, so that they can scan their QR code. We know if they are green or orange, and then automatically they are transferred to dedicated wards, and they go to their consultations following dedicated routes. After the screening of the QR code, we have a final layer of defense, that is that we measure the body temperature of everybody entering the hospital. And on a daily basis, we see 5 to 10 patients on 1,000 of patients entering the hospital who have no signs, who answered the questionnaire that they have no signs whatever, but on entrance of the hospital, they have a fever that they are not aware of. And in most cases, when they are transferred then to the ER, they end up with a COVID positive screening. So for us, it's really important that in an objective manner, we continue to measure the body temperature of everybody. And as I indicated, the red patients, the orange patients, and the green patients, throughout the entire stay in the hospital, they follow separate routes so that we never mix up patients from different code. Next one. What is important, and that's my final slide, I think, is that if you start your clinical activities and you try to limit the inflow and control the influx of patients, you have to very closely monitor what every department is doing, because otherwise you could end up that a big department has a lot of patients coming in, taking a lot of bed capacity, and that smaller departments are shut out and that they don't get the possibility to restart their activities too. So for this means we have 3 layers of monitoring. Before the operating room, we have a daily dashboard of the bed capacity, and we allocated a number of beds to each and every department, and we allow them to go up to 115% of their capacity. And if they reach that level, then we say, well, you have to stop the influx and you have to reschedule some patients because you are using up too much bed capacity. Currently, we are safe. We are around 85% of the capacity throughout the entire hospital. So we don't really have to close out or reschedule patients. But I think in the next week, we will get into this phase that we will have to start rescheduling. Within the operating room, we allocated surgery time to each and every department. You can have one ward 1 or 2 days or 3 days or 4 days a week. You can have a day on Wednesday, an entire day on Thursday, and they have to remain within the allocated time slots. certainly for their semi-urgent and elective surgery, of course not for the acute or very urgent surgical procedures where we built in some buffer capacity. And then probably the most difficult part is the post-OR monitoring, the critical beds, the ICU beds, the monitor beds, because we still have a large proportion of the ICU beds that are taken by COVID-19 patients. So we are above 25% of our regular ICU capacity that is still taken up for COVID patients. So we had to increase the regular number of ICU beds by about 25%. We normally have 5 ICU units. We now have ICU 6 and ICU 7, which are newly based additional ones. And so we try to monitor and make sure that we have enough capacity for the non-COVID related pathology. And of course, if we don't have enough non-COVID ICU beds, then this has implications for the surgical departments, and we have to scale down their activity. So it's a very dynamic daily monitoring of who is coming in, who wants to operate, what kind of operation. We have to have a mix between ICU needing operations and daycare surgery, admission procedures, and we have to keep track that this mix is very valid, and we certainly have to track our availability of ICU beds. Next one. And this is my presentation. Thank you.
Thank you very much, Dr. Hans, for sharing your experiences with us. We will now move on to Dr. Serdar Gunaydin. Dr. Gunaydin received his cardiac surgical training in several countries, including Turkey, England, and the Netherlands, and was a clinical fellow at Heinrich Klein University in Dusseldorf, Germany, as well as the Heart Institute of Japan. He completed his PhD in tissue engineering and biomaterial sciences at Tokyo University. He's well known to all of us. He's published extensively on biomaterial conformation to reduce inflammation associated with cardiac surgery and cardiopulmonary bypass, and leads many national and international projects on patient blood management. He's currently a clinical professor in the Department of Cardiovascular Surgery at Ankara City Hospital Campus in Ankara, Turkey. The title of Dr. Gunaydin's presentation is Getting Patients Back on Cardiopulmonary Bypass, Clinical Aspects. Dr. Gunaydin.
I think you're on mute right now.
Okay, can you hear me now?
Yes.
Okay, yeah, okay. So thank you very much, and thank you very much for the invitation by Joint Perfusion COVID-19 Task Force. I'm working in Ankara in the City Hospital campus. It's one of the largest hospitals in the area. And we have so far about 600 COVID-19 positive patients in the hospital. And we have a very good backup for the ICU and the operating room facilities. And we are doing about 150 to 200 ECMOs a year and 4,000 open heart cases we used to do. I'm not sure about this year in this hospital. So as you know, this COVID-19 has really affected the world very badly. Now we have more than 4 million patients worldwide and about 300,000 deaths. And the first case was reported in Turkey in early March. And now we are planning to go back to our normal routine in early June, because in the meantime, we really want to postpone the routine scheduled cardiac cases, and we did only emergency cases in the meantime, but the hospital was really, let's say, 3/4 was full of with the COVID patients in the ICU units. And as a Society of Turkish Cardiac Surgery, we published new guidelines and emergency protocols of handling COVID patients in the clinical practice. So, but now we are in Turkey, we are nearly in the end of this the first level of this pandemic, and we're going to the second level. Unfortunately, we're just going back to our normal routine, and we're going to have more COVID-19 patients maybe. And so we have to change our normal approach to the patient. We have to find something new, something normal, new normal, we can say. So as you know, the STS COVID task forces published some kind of guidelines to how to select patients or which patients to operate in the early days of the pandemic. And 2 days ago, they published another one describing some facts of how to go back to our normal routine. And they just write down 10 different prospects how to make the centers go back to their clinical routine. And now, from my point of view, I'm going to speak only the cardiopulmonary bypass. So I'm taking the level from Professor Hans to just, I accept the patient now is in the OR, and we are back in our routine and how to manage this patient. So first of all, we must know that these are all high-risk cases, because if they are COVID positive, that means they may have some hypercoagulability problems, hyperinflammation problems, associated disorders. This is one point. If you're not sure if they're COVID-19 positive or not, these are patients who were postponed. So that means in the meantime, they may have some additional problems that we are dealing with, again, with the high-risk patients. So we need to take every precautions we can. We have to be very much prepared that the laboratory levels are not normal in these patients. And so we have to prepare ourselves beforehand, before the CPB management. And during the CPB management, my time is very short, so I only briefly will summarize. So very brief myocardial protection. Fluid balance is very complicated because we operated some patients in this period. And when we have these patients, they're usually coming from the ICU unit. And we're not sure if the fluid balance is positive or negative way, because they may have some pulmonary edema, or they may have some, under volume patients we can face in the operating room. So we have to decide correctly. And anticoagulation monitoring or management is, this time it's different because of the antithrombin level differences. Transfusion is another problem, because still in our hospital, we really have a very shortage of donation in blood. And so we really have difficulty in finding blood to start the operations in those patients. So we prepared this table for the CPB management, some kind of important points to underline. So of course, we need to do some higher level of staff protection, it's for sure, because I will also cite later that there may be some kind of problems in the splashing or aerosol generation of the heart-lung machine, oxygenators or anesthesia machine, or everything that works on the gas in the OR. So the heparinization and coagulation monitoring should be different, because we have low AT levels in these patients. They may go up to disseminated intravascular coagulation later. So we have to be very, carefully monitoring those patients. So if you have some thrombosis in the CPB equipment, we did have in the ECMO patients in our clinical practice before. So we may think to change heparin with direct thrombin inhibitors. So we only have bivalirudin in Turkey as an alternative. It's also very much difficult, to manage bivalirudin in those patients. So it's a very difficult decision to make. And so we need to be prepared for the hypercoagulability if we need some like peripheral cannulation or whatever. So this may be a problem. And of course, the air leak, as I told you, the aerosol generation is a problem. I will cite this later again. Of course, we may avoid vacuum-assisted venous drainage because of those gas and aerosol problems. Because of the problem in the blood supply, and also blood transfusion has some kind of extra problems. One, this virus may be contaminated via blood. We don't know. There is no publication that's giving full evidence on that, but it's a possibility. Another problem, there are some papers that were not verified later, but that virus can attack some parts of the heme molecule in hemoglobin and may cause some hemolysis later. So we need to avoid using transfusion as much as possible. So we need to obey all rules of blood transfusion. So cell salvage is one of those branches, I believe. And ultrafiltration, because of the volume balance, if you are not sure, is another a good way of supporting the patient. And we are always talking about the hyperinflammation. So we have many publications documenting that those patients have very high levels of interleukins. And so we maintain the cytokine infiltration. We did, in the OR, we did 6 cases in this time, and we eliminated about 35% of the high levels of interleukins in this CPB management. But in the ICU, we also use cytokine filtration, and it works much better if you do this filtration in the ICU. As I've told you, I was going to mention about some problems with the gas and the aerosol problems. So oxygenators are one of those problems. So, when we're talking about the ECMO oxygenators, they are all covered with surface coated with the polymethylpentane. So this is a very good surface coating that doesn't have any kind of leakage in the long term. But when we're talking about the routine surface coated oxygenators we are using, we are not sure. There is no paper. So I did a very simple research in one of our patients in the ICU under ECMO. That patient was COVID-19 positive. That was verified by this PCR testing. So I took 2 samples from the different parts of the oxygenator, and the ECMO oxygenator, of course, on the second day and at the end of the first week, and 2 tests were negative. So patient was positive with COVID-19, but these 2 tests were negative for ECMO patient, for ECMO oxygenator. But of course, I don't have any experience with the usual oxygenators we're routinely using in the OR. So this is one point, very important. And the other one is to control all kind of gas exchange with the anesthesia machine, with the oxygenation, and in the ICU. So we have to be always careful while using all of those stuff. Simulation has a good place in this COVID-19 management, as I believe, because now we are starting a new era. We have different rules, so we have to just create some simulation scenarios to manage all our staff, perfusionists, surgeons, anesthesiologists in the room, to handle, let's say, the different scenarios linked with the COVID-19 patients. I believe this is the right time to use the simulation scenarios in those patients. So as a conclusion, we are now going in the second step, at least in our country. We are going to start our routine, a new routine, let's say, in the beginning of the next month. So we start the preparation, everything in the OR, modifying everything, modifying our clinical practice. But of course, there is not any science behind this. It's only a story of a 3-month, we only have a 3-month history, no evidence, nothing. So our experiences, some papers, some guidelines. So this will be a very different, very exciting new challenge for us to manage those patients undergoing cardiopulmonary bypass. We will have many, many patients. Either it is proved to have COVID-19 positive, or we're not sure. Because when we are doing emergency cases, we always face those patients. They're coming like an emergency cabinet, let's say. When we have a CT, it looks like COVID, but when we have a PCR, it looks negative. So we're never sure if those patients are really COVID-19 positive or not. Some of them, we had 3 patients that were negative in the beginning, and after 2 days, they turned out to be positive after the operation. So these will all be new stories in the meantime. Thank you very much.
Thank you for your presentation, Dr. Gunaydin. Excellent. Just to remind everybody, put in your questions. We are monitoring them. You can either do it now or when we're done. This is for Al Stammers, and it's an inside joke, but we will, next will be Dr. Michael Firstenberg. Dr. Firstenberg is a board-certified thoracic surgeon practicing adult cardiac surgery at the Medical Center of Aurora, Colorado, where he serves as the chief of cardiothoracic and vascular surgery. He holds adjunct appointments at the College of Medicine, graduate studies at Northeastern Ohio Medical University, as well as teaching faculty at Rocky Vista University. He attended Case Western Reserve Medical School, received his general surgery training at University Hospitals in Cleveland, and completed his fellowship in thoracic surgery at the Ohio State University. He has also obtained advanced training in heart failure surgical therapies at the Cleveland Clinic. He's an active member of many societies, and he is the author of well over 200 peer-reviewed manuscripts, abstracts, and book chapters. Of note, he is also known for his topics ranging from medical leadership, patient safety, endocarditis, ECMO, all of which topics that he has lectured on worldwide. Dr. Firstenberg, thanks for coming.
My pleasure. Hopefully everybody can hear me. And this actually isn't a Zoom backdrop. This is, we live out here in Colorado, so that's the window behind my office. And I want to appreciate everybody for joining us today. I know that time is short, so I'll be kind of quick, in part because this is a topic, that we could probably spend hours on, particularly since it is moving pretty quickly. And I want to kind of gear this more towards the audience, and because it's going to be a lot of terminology and concepts that I think that we're all picking up pretty quickly. Just as a little bit of a disclosure, we are going to be discussing non-FDA approved therapies, and because of my interest in it, and I have no other involvement in it, I do own a little bit of stock in the cytosorbent company that we're going to be talking about shortly, and you'll see why. So a little bit of a brief history about coronaviruses overall. They are RNA-type viruses that cause diseases both in mammals and in birds, predominantly respiratory tract infections, as I think we're all dealing with right now, and the severity of it varies tremendously. And part of the problem is distinguishing them from things like the common cold to all the way up to the flu, or even some of the respiratory collapse that we're seeing, is a real challenge. And I think something to keep in mind, particularly as we get into, quote, flu season, we're distinguishing between the two of them. Without getting into too much of the detail, it's a very complex structure. And the reason why it's called a coronavirus is, as you can see from the color model at the top there, that it actually looks like the corona of the sun, and that's how it got its name. Unfortunately, there are no vaccines yet. There are no proven antiviral or effective therapies, and yet we're going to talk about some of the things that people are thinking about. To kind of put it into perspective a little bit, as you can see, and I borrowed some of this from Wikipedia, that the current coronavirus that we're dealing with, SARS-CoV-2, is very similar to the coronaviruses that caused outbreaks predominantly in China and Saudi Arabia years ago, that had pretty substantial impacts on the overall local communities there, but fortunately were contained enough that they didn't go worldwide. And this slide, unfortunately, is about a day or two old, because anybody that's tracking this stuff knows that these numbers are continuing to increase on a day-to-day basis. But worldwide, currently over 4.2 million confirmed cases, with coming up on close to 300,000 deaths. And again, without getting into the politics of it all, a lot of that is also based upon how you count the cases and the mortality. But nevertheless, at least in New York, they are reporting an up to 8% case fatality rate for this. And you can't turn on any news thing and not recognize that this is a real problem. And in fact, in this slide, which there'll be a test on this at the end, and this is not DNA sequencing, but rather you can see that these are all the countries of the world that are impacted by COVID right now, in terms of the total number of cases, the case fatality rate that ranges from less than 1%, if you believe the data coming out of Russia, to as high as 15% in the United Kingdom. But it really affects everybody across the world, and these numbers are constantly changing. So really the question is, what do we end up doing about this? I think for the most part, I think people are quite familiar with the supportive technology therapies, and that is just to get people over the hump. Without a doubt, many of these people are hypoxic. Oxygen therapy is clearly a first-line therapy. There's been a lot of innovation towards prone ventilation, even people that are not intubated. In some parts of the world, they're sending people home and just telling them to sleep on their stomach, and that has a profound effect. We do see hypercoagulable states that are advocating the use of anticoagulants. Many of these people, because of impact on the renal tubules that are still being understood, go into renal failure. We are seeing a lot of evidence of acute pulmonary hypertension, almost similar to pulmonary embolisms, that are accounting for some of the mortalities and specifically right heart support. Mechanical ventilation, people are debating back and forth really the ideal ventilator settings, but unfortunately a lot of these patients are profoundly hypoxic and in respiratory failure. I think everybody on this call is probably familiar with the growing role of ECMO in those patients that are profoundly hypoxic or hypercarbic, or as a way of supporting total cardiopulmonary collapse. But for the most part, a lot of the therapies that are being offered out there are supportive. Nevertheless, and without going over all the basic immunology and virus sciences, there is a very aggressive, which is an understatement, amount of energy that's going into understanding the mechanisms by which the virus has been shown to attack some of the ACE receptors in the lung and multiply and result in what is sometimes seen as this very profound immunologic or immune-mediated response, and how to attenuate that. And so just briefly, as you can see, in the entire life cycle of the virus, from the time that it enters into the host cells to the replication and the effects that it has on the body, there are various opportunities that people are targeting to try to interrupt the catastrophic effects of this. Just highlighting some of the therapies that are out there that many people have heard on. Part of the problem is we don't necessarily understand the mechanisms by which all this works. This has only been going on for a couple of months. And as you can see, we're still getting a handle on, for example, HIV that people have been studying for decades. Hydroxychloroquine and azithromycin, typically used for anti-malarial, have some non-specific antiviral activity that is quite controversial, as you know. There's a variety of protease inhibitors that are similar to what is used to control HIV. A variety of antiviral type medications related to whether interfering with nucleoside analogs or remdesivir, which we'll touch upon a little bit later. Interferons are being used. Steroids to attenuate the anti-inflammatory response have some questionable role, particularly later on, to minimize some of the pulmonary fibrosis that some of these patients are getting. However, there is some concern that early use of steroids may actually increase the viral spreading and viral replication. We do know that one of the problems related to this is this, quote, cytokine storm that is mediated by the interleukins, and in particular IL-6, and some of the drugs that I can't even pronounce that are used in the chemotherapy world are being used to try to minimize that. There's a tremendous amount of energy on convalescent serum, which is geared towards potentially, I guess, jump-starting the immune system by helping people fight this off earlier, high-dose vitamins, as well as a variety of monoclonal antibodies that may help in the immune-mediated response. There's also some mechanical solutions that I'm going to touch on in a second. Without a doubt, remdesivir has gotten the most press lately. There's been a variety of papers in the New England Journal at the top there, The Lancet and JAMA, that are all touting its potential role. And I say potential because I think we're really starting to understand now the limitations of this drug and how it may be applied. Just briefly, it's a monophosphate prodrug that gets converted over to an ATP analog that plays a role in inhibiting viral replication. It was first found during the development for other coronaviruses, as I mentioned before, and the flavonoid viruses. And in particular, there was a lot of enthusiasm in using it against Ebola. And that's where really things kind of became very exciting, there were some benefits in case reports, but as that started fizzling out, there really wasn't as much interest in it, but nevertheless, Gilead took it over for potential use down the road. The mechanism of it is unclear, particularly in renal and hepatic patients, which is why we have to use it very cautiously in those people. And we're still trying to understand the dosing for different age groups, patient size, and especially for those patients that are on ECMO or renal replacement therapy. Right now, the current literature suggests a lot of excitement in attenuating the disease severity, but as of now, there really doesn't seem to be a lot of evidence to suggest that it reduces mortality. People think essentially it's similar to Tamiflu, and that is if you take it while you're infected, some people will have a benefit, and that benefit typically will translate into getting over the infection quicker, but does not necessarily reduce the amount of complications associated with it. The real problem is that they just can't make the drug fast enough right now. Gilead has the licensing for it, and they are working on pumping it out as much as possible. And when you think of a drug geared towards treating millions of patients over the course of a couple of, that have gotten sick over the course of a couple of months, it really is a huge problem trying to ramp everything up. And that's part of the politics of all this that I don't want to get into. As I mentioned, one of the other problems related to the substantial morbidity and mortality that comes from COVID that we're seeing is, quote, this cytokine storm. Cytokines, for those of you that are not familiar with them, are small proteins that can help stimulate or regulate the immune system and control inflammation. What we do see in a lot of these patients is that there is this complete breakdown in the autoregulation of the immune and inflammatory response. And many of the patients that we are seeing that actually die from this are dying more of complications of this immune-mediated phenomenon. And it's a very complex feedback loop, and when there's a destruction of it because of this potential infection, you get this systemic inflammatory response syndrome, which some of you may be familiar with from the early days of perfusion therapies, but nevertheless, they can be catastrophic, and that's what's leading people to focus some of their attention on how to treat it. One of the things that's become very exciting right now are some of the mechanical therapies, and one in particular that I mentioned is this filter that is filled with porous beads that are very similar to grains of salt, similar to a dialysis circuit. And the way that it was designed is that the large particles or the large substances like blood cells move around it, but because of an electrolysis type process, it does attract some of the medium-sized particles that are geared or tuned in for these inflammatory markers. And as a result, some of the hydrophobic substances, such as the cytokines and some of the various endotoxins that we see in sepsis, actually stick to these beads, and it serves to filter it out. Cytazorb, as mentioned, is one that many that are out there. And as you can see, there's a variety of these particles that exist in the bloodstream that help mediate this response, ranging all the way on one end to some very small particles like bilirubin and some of the different toxins that could be filtered out with dialysis, to some of the larger inflammatory markers like TGF-beta, interleukins, and as well as some of the toxins that come from, example, pancreatic problems, as well as then all the way at the other extreme, some of the larger particles that I mentioned that don't get filtered through, like albumin and hemoglobin. And the real benefit from some of these filters is, instead of medical therapy to attenuate this inflammatory response or to treat it, in what is generally viewed as a very benign therapy, you put these filters in along the lines of either an ECMO circuit or a dialysis circuit. There are reports that they can be run independently through a pump, which is why those of you that do perfusion may be seeing this more and more, and that is it's essentially a mechanical filter for trying to get out some of these cytokines and inflammatory mediators to attenuate this response. And so as we kind of widen things down a little bit, right now, I know in the interest of time, and hopefully we'll have time for question and answers, and as I mentioned, there's a lot to talk on this, but really the current focus on COVID therapies are supportive care, of which ECMO, as we all know, is not a treatment, but more or less something to support the patient as the heart and lungs get better. we need to recognize that this is not a singular disease and we can't treat every patient the same. Every patient has different types of presentations ranging from neurologic to renal failure to respiratory failure, the full spectrum of problems. And there's really a very aggressive worldwide search for finding the right drugs and therapies, but it needs to be for the right patients and at the right times. Starting some of these antivirals, for example, weeks into a clinical course may not attenuate it. And that's, I think, one of the problems with some of these remdesivir trials. If people are symptomatic for days or asymptomatic for a week or two, we may have missed a window of opportunity to really intervene in a way that we can attenuate the overall course of illness. So fundamentally, we need some good protocols, some objective science, and really what we're seeing, unfortunately, is that we're just at the beginning. And fortunately, we're able to draw on some old ideas like convalescent serum, which has been used for over 100 years now, and mixing it with some of the newer ideas like some of these immune modulated therapies, both medical as well as mechanical. And the picture here just illustrates one of our recent ECMO patients. He was on ECMO as well as dialysis for over 2 weeks for COVID-19. And here is a picture of him about to go home the day before discharge with normal renal function. Everyone up here in Colorado needs oxygen by the time they leave the hospital. I probably need it after a long day, but more or less normal pulmonary function. And, you know, unfortunately, a lot of times the therapy for all this, not just for the patients, but for the providers, is sometimes just a few Girl Scout cookies to get us over a difficult hump. And these are just some of the donations that we've been getting to support all the providers that are doing heroic efforts, much like many of the people on the call. So thank you for everybody what you guys are doing. And hopefully this helps lend a little bit of insight into the complexities of the challenges that we're facing in treating this really complex and difficult problem. So hopefully we'll have some questions and answers at the end. Thank you.
Thank you for your presentation, Dr. Firstenberg. Really good information. We'll now get started right away with our Q&A portion of the webinar. So for those of you, there are some questions on the Q&A, and I'm sure our moderators have questions as well. So Al, do you want to start? Do you have something right away? If not, I can.
Thanks, Bill. Yeah, let's go ahead and begin with a couple of questions on cardiopulmonary bypass. These are for Dr. Gunaydin. The question is, if a VAVD is being used in a closed circuit, can a low amount of vacuum, say -20 to -30, be applied? And if applied, is there any danger with using VAVD?
So we have some publications before. We did some experiments on the clinical setting to measure GME by using VAVD. So in those papers, we demonstrated that when you pass like 25, 30 millimeters of mercury in the pressure, we demonstrate a significantly high number of GME in the circuit. So if this is the case in this setting in the COVID-19, of course, we don't have any experiment in COVID-19, but according to our previous study, the number of GMEs will significantly be more. So that means theoretically there is a kind of possibility of the aerosolization and the danger of the dissemination of the virus by the gas phase, let's say.
Great, thank you, Dr. Gunaydin. Another question that came up was, Dr. Hans, you were talking about reprocessing the respirator masks. Is that true? Dr. Hans, yes? And what test, do you perform tests on the mask afterward for efficiency?
Well, we did it on a batch, and we did it jointly with a couple of hospitals where we infected them for up to 10 cycles and then tested the filtration efficiency. We did also the fitting test. And we currently say that, for example, the FFP2 mask can be disinfected up to 4 cycles. So each and everybody, each healthcare professional gets his own mask back, they write their name on it, and every time they reuse it, they put a tick on it, and we do it up to a maximum of 4 times. So we know that up to 7, 8 times the filtration efficiency is contained.
And what kind of tests were you using, sir? That was another question.
It's in the certified lab that we did it, so it's outside of the hospital that we did it. And we used hydrogen peroxide, so the knuckle spray, and also the chlorine dioxide method. And we are now looking into an ozone disinfection method. So we try to keep 2 or 3 different methodologies so that we can use it in a very broad way.
Thank you. Dr. Firstenberg, you're muted, but I'll go ahead and ask you the questions.
Okay, I'm muted.
Between phone calls. I understand. Do you know if there's differences in the filters that are being advertised out there, Cytozor being one of them? I've seen another company come out. Do you know if there's actual structural or efficiency differences at this point in time?
Well, I think part of the answer is people are still trying to figure that out. I mean, these filters have been around for a while. And in fact, when I brought them up to our nephrologists, thinking that it was relatively new, they were very excited about it because one of their colleagues did their PhD on it. And so a lot of it is based upon different size in terms of the efficiency of it, as well as the nature of the particles that they filter out. But essentially, they're all fundamentally the same. They don't want to, they got to let all the small stuff through, and then they have to let all of the bigger things also through. So just trying to capture it. And the way that they also work is that they don't take it all out, much like a dialysis circuit. They help sort of achieve a reasonable equilibrium. So for the ones that we're using, they do filter out the interleukins, but hopefully maintain enough of a balance so that the body's immune system can get back into regular homeostasis, as opposed to just taking it all out, which may result in the pendulum switching in the other direction.
Great. And on the same question there, and I think I've heard this answered before, but the question was rebound, or using it beyond the first one, replacing it, and seeing that cytokine storm possibly happen again after the first therapy.
Yeah, and that is something, so the way that at least they're fundamentally designed is that, you reach a steady state or a balance within a couple of days. And I think that it's not a huge leap of faith to realize that if you haven't put out the wildfire that contributes to releasing all of this, that it'll continue to go on. So if you start, we've seen, levels, that are astronomical off the, unmeasurable, and then come down within 24 to 48 hours. And that just reflects the efficiency of the filters. And then when you stop the filter, if you haven't stopped the process, then it goes back up again, and you may have to reinitiate therapy. Part of the problem in all this is, even if you talk to the people that are making the filters that have a huge experience in, other areas of sepsis, that the experience with COVID-19 really is evolving very quickly. And in fact, they're constantly emailing us because they want to know what our experiences are, because everybody's learning from this. And it's the most common applications of them have been for, let's say, endocarditis or bacteremic sepsis, where you treat the endocarditis or you drain the intra-abdominal abscess. This is a completely different set of circumstances. And that's why I think we really need to start being smarter and having an approach to how we're dealing with these problems, not just, at the early phases, just treating everybody with whatever tools we had in our armamentarium.
Thank you.
We also have some experience with the cytokine filters. So we have 6 different products available in Turkey. Most of them are being used in the ICU units, not in the OR. Probably because of the pressure differences when you're connecting it to the CPB or whatever. But they all really filtrate, let's say, about 35 to 40% in our experience of the cytokines in the circulation. And there was a question about rebounding. We see a couple of patients in the ICU that if you drop down the cytokine level very quickly in, let's say, 6 or 8 hours, because we usually spend like 1 or 2 days to get the normal levels, or let's say acceptable levels. If you drop down very quickly, then we have a rebound in those 2 patients.
Very cool. Luke, do you have a question?
Yes, there is a question for Dr. Hans from Antwerp. There's been a study in Italy about out-of-hospital cardiac arrest. That there was a 58% augmentation in the number of cardiac arrests outside of the hospital. Do you have any experience seeing that in Antwerp? And what do you do with the ECPR program now in Antwerp? Have you suspended it, or do you take special measures?
Well, that's a good question. First of all, during the height of the pandemic, we saw a decrease in cardiac arrest, and we saw also a decrease in myocardial infarction. We saw a decrease in stroke patients, and we were really worried on it. And several of my colleagues got on television, and myself too, saying, well, where are all of these patients? Because we don't see them anymore. Afterwards, they started to come in, certainly first the stroke patients. We had some pretty dramatic cases of children with ruptured appendix, and they came in with a very pronounced acute abdomen. So really people were afraid of coming to the hospital, and they waited too long. For the ECPR program, we came up with a new protocol because we tried to limit the number of people assisting in the ECPR procedure. We took care of the isolation measures and everything. So we rescheduled, rewrote, the colleagues from the ER and the ICU rewrote the protocol so that they could do it in a safe way. And we had some triaging system. We said, well, we're going to keep the current ECPR program with the current indications as long as we get. Then we could go to a phase 2 when we have a limited capability of ICU, and even to a phase 3 if we really get into a large surge and we have no ICU capabilities any longer. But luckily, we could manage it, and we didn't have to scale down the ECPR program. So we, at every moment, we had enough ICU capabilities and capacities so that we could continue our ECPR program. But certainly in the first week, we had a decrease of 40 up to 50% of patients coming to the ERs in Belgium, and it was a global effect that we saw.
With that in mind, I had another question for you. Do you think, like in a country like Belgium, where the number of hospitals is quite big and it's a limited population, do you think it would be feasible to dedicate 1 or 2 hospitals solely for COVID-19 patients?
Do you have power?
In China?
No, well, that was at the beginning the approach of the government. So they said there are 2 reference hospitals for Belgium for COVID-19. And that was one hospital, St. Peter in Brussels, and our hospital. But we are also the reference hospital for Ebola and everything. So we are used to that. And then they said, well, if we have a surge, then we will go to the university hospitals, the 9 university hospitals in Belgium. And if we have a very large surge, then we will go to all other hospitals. They maintained that for about 1 week. For 1 week, all patients were brought to the reference hospitals, the 2 reference hospitals, and then they let it loose and they opened it up to all other hospitals. So they skipped the second phase. I'm not sure that was the right decision because we saw a pouring in of patients on the ICUs. The severity of the conditions on the ICUs were very different between the hospitals. What we take care of in a normal ward was put already on an ICU in smaller hospitals. So I'm not sure that was the right decision of the government that they took, and we will certainly reconsider this after everything has calmed down.
Okay, thank you.
We have two questions on timing. And the first one for Dr. Gunaydin is, if a patient tests positive, how long should you wait, this is for elective cardiac surgery, before you would consider doing the operation on them, assuming that they would test negative at a later time?
We have a kind of intermediate ICU unit in our hospital. So we just transfer those patients to this intermediate ICU unit and follow up for another test. And if the next test is also negative, then it's okay for us.
Okay, thank you. The other question, this is for Dr. Firstenberg.
Yeah, can I comment on that for a second? You know, I think, you know, as everybody is kind of getting geared up towards starting up again, there is a lot of concerns about doing surgery in patients that are COVID positive. And, you know, there was a paper that came out of the Journal of Thoracic and Cardiovascular Surgery looking at people that had lung surgery, and they had a very high mortality rate. We published a case a couple weeks ago about a CABG patient that did very poorly after surgery, who subsequently turned out to be COVID positive. And in talking with colleagues, and maybe those of you on this call, you know, have seen similar cases, but I think that there's a huge concern that even in patients that are asymptomatic, that are needing cardiac surgery, the need for cardiopulmonary bypass really can flare up this whole immune-mediated response. And I think that there is a growing reluctance to undertake anything until we have a better understanding. And in talking with, you know, surgical colleagues around the world, they're having a very low threshold for sending these patients to PCI, or sending them for, you know, even low-risk patients for TAVR, or delaying their surgery as much as possible. This is, you know, we're charting uncharted waters here, and I think people are really starting to figure out what's going on. And I know that we're very reluctant to consider operating on anybody that may be COVID positive.
If you have somebody who's COVID positive and you wait for a couple of days and you do a retesting and it turns out to be negative, do you do then a second negative testing after 24 hours, or are you happy with one negative test? Because that's the debate that is going on in our hospital. Do we need two consecutive negative screenings or not?
I'm not sure people turn negative that quickly. I think that, you know, I remember from day one of medical school saying, you know, if somebody comes in with a problem, you have to understand what the problem is. If they come in with a STEMI, if they come in shortness of breath, and they subsequently turn positive for COVID, the current assumption is that it's related to COVID, not their underlying heart failure or coronary disease. And that the time course of this, I mean, we've had people that have been, you know, that were on ECMO for weeks and they still are positive. You know, I don't think anybody knows when people are going to, you know, how quickly the immune response is going to turn them negative. And a lot of that also gets into the types of testing that are done, the sensitivity and specificity. You know, there is a lot of immunology that is way above my level of understanding, that I think it's way above a lot of people's level of understanding. This is not like a urinary tract infection where somebody comes in, they have they have bacteria in their urine, you give them some antibiotics and they're better 2 or 3 days later. I mean, there are people that are still shedding virus a long time after this.
Also, if a patient turns negative, how long does the consequences of having being positive last? I've heard some reports of people being sick, then healing, and then they have a pulmonary emboli or they have a stroke afterwards. Do you need to look at, I know you don't have the answer, but maybe we should look at specific markers of inflammation caused by going through the disease, even without symptoms. Any comments on that? No. That's what I thought. Sorry.
That we see
I don't have any comments because I don't think anybody knows right now.
Yeah.
I mean, we see people getting better and they go home, but that doesn't necessarily mean that they're over everything that's gone on. And the other thing that people are seeing is that even in relatively asymptomatic patients, I mean, those that come in and they go home on a little bit of oxygen, they deteriorate substantially at home. There's people that are dying suddenly, and I don't think anybody knows why. There's, we're unfortunately just in the infancy of understanding this stuff. So
maybe we should, like when patients are declared healthy or virus free, we should still be very cautious when trying to operate on them if they need surgery. And
yeah.
Yep.
And we have a monitoring program, and we have patients who are sent home after 3-4 weeks of hospitalization. They have no symptoms left, but we monitor them at home with oxygen saturation, with activity trackers. And we see that they keep on having very low oxygen saturation of 88, 89% in rest at home. And we call them up and they say, oh, I'm very fatigued, but for the rest, I don't have any symptoms anymore. And still they have very low oxygen saturation. So that kind of worries me.
Mm-hmm.
Al, you had a question that was real popular. Can you bring that up before we have to end?
Yeah, I can jump in
Well,
with it's what will be used. This one is from Diane Gonzalez, and it's what will be used for cytokine filtration during CPB. And are there any recommendations or suggestions for use of this device in CPB circuit?
That's the one I was talking about, Al.
Thank you.
Dr. Firstenberg, you want to take that first?
Sorry, I got distracted with the
No
text.
problem. Talking about cytokine filtration on CPB in conjunction with CPB, that aspect. We talked about it with ECMO. We talked about it in ICU. You mentioned it in intraoperative.
Yeah, I think there's some pretty robust literature from the company about using it in non-COVID inflammatory states. In fact, the most robust literature that they have is for like sepsis and endocarditis. And, they feel that it's something that can be very easily used both preoperatively, postoperatively, and apparently has relatively minimal effect on all the dynamics of cardiopulmonary bypass. In fact, they feel that the faster you run blood through it, the better it filters it. So if it's something that you're interested in, in the interest of time, I would just, kind of point you to their website where, there's a lot of papers and literature about how to use it in some of these other circumstances. I'm not quite sure there's any data in using it in patients, with COVID in the operating room yet. But if I had to do, let's say, an aortic dissection or some catastrophic problem emergently, and the inflammatory markers are elevated, then this is something I would definitely embrace. I think the key is that this stuff only works when the inflammatory markers are elevated. Just because somebody's sick, that doesn't necessarily mean that they have cytokine storm. And we've seen people with very high cytokine levels that are doing reasonably well, and we've seen them pretty low. So the first thing to start is get a ferritin level, maybe start looking at D-dimers as well as C-reactive, although your C-reactive proteins are not always elevated. And if you can get interleukin levels, that could really help guide therapy a little bit. So
Thank you very much.
Yeah.
Any other story from the doctors? Otherwise, this webinar will be posted on the Joint Perfusion Task Force within 2 days. After the conclusion of this call, all attendees that have joined us on their devices will be provided with a link to complete a survey to claim credits and provide us with feedback on the status of your program's operation at this time. The link to the survey will also be automatically emailed to all participants one day after the conclusion of this webinar. Results will be shared on our next webinar. We would greatly appreciate your participation in this survey to help guide our future work. Please do not forget to answer the survey to be able to claim your CEUs. I want to thank Medtronic for their sponsorship of today's webinar. And Al?
Yes, it's important too, if your question was not addressed today, if we didn't get to it from the list, please join in the discussion on the Joint Perfusion COVID-19 Task Force website, and questions will be answered there. And you could also post other questions to enter into the discussion forum for input. And all individuals are able to address questions and answer them, not just the panelists, and also members from the task force. I'd like to thank all the speakers, the panelists, all the participants who joined us today. Kate for organizing this from AMSAC, and also please, we invite you to join us on May 28th for the next webinar, which is really going to be focusing on getting back to normal, looking at supply and demand, and we'll hear from our manufacturers at that particular time. So again, thank you. Thanks, Kate, AMSAC, Medtronic, and everybody for participating today. And we hope everybody has a great day. Thank you.
Thank you.
Thank you.
Thank you.